Okay, we are going to discuss now the spinal injury. First of all, we'll discuss about the basics of spinal injury. These are the learning objective of this module. At the end of the lecture, the student will be able to identify the spinal injury, initial assessment and rescue, final assessment, imaging, and initial management, and then how to refer and transport the patient. First of all, before going to discuss the spinal injury, we'll have to discuss a little bit about the spine and spinal cord. The spine is made of the bony structures. Then, along with the bone, the vertebra are the paraspinal muscles, and then there's the nervous tissues, the spinal cord, and nerve roots. These are the composites which make the spine. So this is another picture. You can see this is the bony anatomy, this is muscular, and then is the neural tissue. These three components are very important to know, and their anatomy that's relevant to treat the patient of spinal cord injury. Then we have to know spine is one of very mobile segment, but there are four most dynamic areas of the spine. We'll see this is the craniocervical junction, this is the cervical and thoracic junction, this is a thoracolumbar junction, and then end of the lumbar, start of the sacrum. These are the most load-bearing and mobile areas of the spine. We have a scenario, a 30-year-old laborer, while working on the second floor of the building, he fell from the ground. And when he was approached, he was having a severe pain in his neck with the tingling sensations of the hand, trunk, and he was unable to move his limb. Now, how will you proceed this patient? How the management of spinal cord injury starts? It starts in the field. When it's the site of injury, wherever the injury is there, you start managing from there. When we see a patient with a trauma, with an accident, with some another incident, first we have to identify which are the patients with spinal cord injury. So these are typical features where we can directly or indirectly relate to that the patient is having some sort of spinal injury. Patients with major traumas, where the loss of consciousness is there, are patients with the minor trauma victims who are having back pain or neck pain. Or there is a tenderness at that area. There is any abnormal feelings like tingling, weakness, or any other like paralysis or anything related to the neurological injury. You can examine abnormal breathing patterns. The patient can have priapism. If anything of the above is there, you can think the patient is having spinal cord injury. How you will assess the patient with the spinal cord injury, and then how you treat in the field. It's according to the ATLS protocol. It starts from ABCD. First of all, before going to ABCD, we have to see for C. The C is for catastrophic hemorrhage. If you are having a major vessel bleed, first you have to stop that. You have to press that. You have to hold that. Then you go for the airway, breathing, circulation, any disability, there's neurological deficit, and then is the exposure, E for exposure. How you rescue a patient with spinal? First of all, you have to do the spinal immobilization prior to and before extrication, place the patient on a black backboard. I can show the picture in the next slide. The sandbags has to be applied on both sides of the head with an adhesive tape on the head to fix it. Otherwise, you can have a rigid orthosis like Philadelphia collar. This is a typical rescue of a patient with a spine injury. You immobilize the neck, you immobilize the head, you place the patient on a hard board and then fix from all areas so he can't move to prevent the secondary injury, further injuries. Then you maintain the blood pressure. Remember, there are two killers in spinal injury. Number one is hypotension, and then is the hypoxemia. So you have to keep maintain the blood pressure. If there is a patient in a spinal shock, you go for inotropic sport, you go for dopamine, but you avoid phenylephrine. You go for fluids, you give the patient military anti-shock trousers, masked. This is a typical picture of masked. You apply the pressure on dependent areas so that the blood is not being pooled due to the vasodilatation or due to the spinal shock. There's a vasodilatation and blood is pooled in the dependent areas, so it's not going into the circulation. This is another uh, way of protecting the patient from the spinal shock. You maintain well oxygenation through the nasal mask, nasal cannula, or face mask, or you can intubate the patient. While putting a tube, you have to be careful about the cervical spine, that there you don't extend the neck, and sometimes the nasotracheal intubation is necessary rather than going for the cricothyroidotomy, that you can later on have some difficulties in the spinal injuries patient when you have to fix it from the interior of the neck. So you do a brief motor examination. You just ask the patient to move his arms, move his hands, move his legs, and move his toes so you can check for any motor weakness. Then you transport the patient to the hospital, and the in-hospital management starts again in the line of ATLS. You go for primary survey and resuscitate the patient, then secondary survey, and then you go for the investigations. You go for in the secondary survey. The primary survey is similar, ABCD, and the secondary survey you go for detailed assessment of all system, and in also for the patient of spinal cord injury or spine injury, you go for detailed neurological assessment. You take focus history, you assess the motor level, myotomes, you check for the rectal tone, you check for sensory levels, you go for reflexes, abdominal reflex, chemostatic reflex, and anal cutaneous reflex. You go autonomic system, you go for uh, sphincters, bowel and bladder incontinence. There can be the priapism, clitorism. You palpate the spine in detail from neck to tail of the tailbone. The management is again immobilization. You keep the patient on the hardboard until you have taken the CTs and you have confirmed that there is no bony injuries. You go for treat the hypotension. You give, as we have discussed earlier, give the patient oxygen. You put the NG tube. If there is a risk of vomiting or aspiration, you go for Foley's. DVT prophylaxis is started with the help of pneumatic compression stockings, low molecular weight heparin, or rotating beds. You give the patient cooling blankets to avoid hypothermia. Electrolyte imbalance is checked. No, the imaging. the first line imaging is the X-ray. You go for whole spine X-rays, because if you find a spine injury somewhere, there's a 10% chances of having another secondary spinal cord spine injuries. So always go for whole spine X-rays. You go for cervical spine, AP and lateral view is the most important, but you have to go for both AP and open mouth view to check for the odontite fractures, because on routine AP view there's a hindrance by the jaw, so you can't see on simple AP view about the atlas and axis, so you need open mouth view. For the thoracolumbar spine, you need to have AP and lateral axis. They are enough. If a patient falls from 6 feet and above, he's having a back pain or he's unconscious, go for whole spine X-ray. Whenever you find some abnormality in X-ray, you go for CT and MRI. CT for the bony injuries and MRI for the soft tissue or neurological deficit. Whenever the patient you suspect for soft tissue injuries or neurological injuries, you go for MRI. Oh, the treatment. Treat the basic abnormality. Basically, you must know how to treat a patient according to the pathology. Whatsoever the pathology is, you have to tailor your treatment according to that. The basic pathologies are, they can be the fractures, they can be dislocations, and they can be compression. These are the bony abnormalities, and neurological injury is when there is compression on the neurological or damage to the neurological structures. So, similar principle as the principle of management on any fracture or bony abnormality, you first immobilize that bone, you reduce or align, and then decompress. How you do this? You immobilize with the help of Philadelphia collar or Haloves. You reduce with the help of and immobilize with the help of cervical traction. It's Gardner-Wellstone. And these are the pictures. This is the picture of Haloves. This is a picture of Philadelphia collar. And this is a picture of cervical traction, Gardner-Wellstone. You put the frame on the patient's pin on patient's head, attach it with a weight-bearing system, and you put the weight according to the vertebra involved. And then it's to immobilize and to reduce it as well. And then if it's not reducible or compression is there, neurological structures are being compressed and patient is having neurological deficits, you have to go for either open surgery and decompress it. It's the very important that you have to do within 24 hours if it's needed. And the best time is less than 8 hours. If you do decompress the spine, less than 8 hours, that's the best time. That's the golden time. It's the earliest surgery, but it should not be delayed more than 36 hours. Because after 36 hours, the chances of neurological recovery are minimal. And if the patient is having complete injury, there's no chances of recovery. You have to do the just surgery to stabilize. You can go for up to the 72 hours. First, you have to assess whether the patient needs immediate surgery. If there is neurological, patient is having neurological deficits, or the patient is having unstable spine, you go for early surgery. If you see a patient without any neurological deficit, or there is complete spinal injury, then you just have to align the spine and fix for rehabilitation. Then the hope for neurological recovery is minimal, so you can go for 72 hours. So thank you very much. This is all about the basics of spinal cord injury.